Welcome to our deep dive today. We'll be exploring Tropheryma whipplei. It's the bacteria behind Whipple's disease. Now, I know you all, being medical microbiologists, are very familiar with the world of bacteria. But T. whipplei, I think, has some tricks that might surprise you.
Oh, absolutely. It's been a puzzle for researchers for so long.
Yeah, and we're drawing from the second edition of Principles and Practice of Clinical Bacteriology by Gillespie and Hockey to kind of go through this. So let's start with what made T. whipplei so hard to pin down initially. It's morphology.
Right.
Unlike your typical gram-positive or gram-negative bacteria, this one's got something else going on.
Yeah, it's a rule breaker.
Yeah.
Under an electron microscope, you see a trilamellar structure. So it's 3 layers to the cell wall. And that really threw researchers off.
Ah, so not your average bacteria. And so I imagine this unusual structure also makes it difficult to culture.
Oh, absolutely. Culturing it is not for the faint of heart.
Okay.
It needs human fibroblast cells. It has a very specific growth medium. And even then it grows so slowly.
How slow are we talking?
Initially, they were seeing a doubling time of 17 days.
Oh, wow.
Which is, that's a long time. Now they've got it down to 36 hours, but it's still slow going.
Wow.
So that really hindered early research.
I bet. So culturing was a hurdle. How did they finally classify this bacteria?
Well, 16S rDNA sequencing came along, and that let scientists look at the bacterium's genetic material and really figure out where it fit in. And it turns out it fits in the actinobacteria class.
Interesting.
Which are often found in soil and environmental sources.
Oh, so a bacteria with ties to the soil causing a human disease. How does that happen?
That's been the question. We still don't know the exact mechanism of how it causes the disease.
But I bet there are some clues. What have we found so far?
Well, one of the things that's come up is a link to HLA-B27 positivity.
Okay.
Which is found in a higher percentage of Whipple's disease patients.
So could there be a genetic predisposition?
That's a possibility. And so this HLA-B27 link really opens up a lot of new research.
Very interesting. But let's go back. How does this soil-dwelling bacteria get into the human body?
Well, that's a mystery, too.
Okay.
We've found T. whipplei DNA in sewage water. We found it in human stool samples. But the route of transmission, how it actually gets in there, is still unknown.
So we know it's out there. We just don't know how it gets in.
Exactly. And there's a possibility that it could be a commensal organism in some people.
Whoa.
There have been studies where they found the DNA in healthy individuals.
So it could be just in the wrong place at the wrong time kind of thing.
Possibly.
A harmless bacteria that turns pathogenic.
Yeah. More research is needed to really determine what its role is in health and disease.
Yeah, it seems like every question we answer about T. whipplei just leads to more questions.
That's right.
But how do we even diagnose Whipple's disease with a bacteria that is so difficult to culture and identify?
Yeah, that is where the detective work comes in. Because it really can be a complex medical mystery. You have to piece together the clinical findings. You have to piece together laboratory results. Sometimes it's intuition.
Yeah.
It can be tough.
So how do we do it?
It's a challenge. The clinical presentation is often very diverse.
Okay.
Which makes it even harder.
So what should medical microbiologists be looking out for?
Well, the classic symptoms are weight loss,
Right.
diarrhea, malabsorption, abdominal pain, and arthralgias, or joint pain.
Okay.
But not everybody has all of those.
So it's not always straightforward.
No. In fact, about 15% of patients don't even have the digestive symptoms.
Oh, wow.
So you have to keep Whipple's disease in mind, even if it doesn't seem like the typical presentation.
Right. So keep an open mind.
Exactly.
Now, I've also heard that Whipple's disease can have neurological effects.
Yes. Unfortunately, neurological involvement is pretty common. Up to 80% of patients.
Really?
Yeah. And there are a lot of different ways it can show up.
Like what?
Facial myoclonus, ophthalmoplegia, dementia, ataxia, memory loss, seizures, and even something called oculofasciocervical myarrhythmia.
Oculofasciocervical myarrhythmia. That's a mouthful.
It is. It's basically a rhythmic jerking in the eyes, face, and neck. And some people consider that pathognomonic for Whipple's.
Wow. So the classic symptoms can point you in the right direction, but those neurological signs really clinch it, huh?
They can be very suggestive, yeah. But we do need lab confirmation to be sure.
Okay, let's talk lab diagnosis then. What are some of the key tests for Whipple's disease?
Well, as we said, culturing T. whipplei is not really practical. It takes too long. So the gold standard has been PAS staining of duodenal biopsies.
Right.
And that's where you see those foamy macrophages that are filled with the bacteria.
The foamy macrophages. But PA staining isn't foolproof, though, right? It can pick up other things.
That's true. It's not specific for T. whipplei. You can get a similar pattern with other infections. So that's where PCR comes in.
Oh, PCR.
Yeah.
That's the workhorse of microbiology. So how does that work for Whipple's?
So PCR lets us see the DNA of T. whipplei in different samples. Biopsies, cerebrospinal fluid, even joint fluid.
Okay.
And it's especially helpful in those atypical cases where maybe you don't have the gut symptoms or the PAS stain is unclear.
So it provides more confirmation.
Yes.
Especially in tricky cases.
Right. And sometimes PCR can be even more sensitive than PAS staining, like when you're looking at CSF.
But that's interesting. But I thought I read that PCR on blood samples wasn't good for Whipple's.
Yeah, that's because blood can have inhibitors in it that mess with the PCR, so you can get false negatives.
Ah, okay. So PCR is great, but it's not perfect.
Yeah, you have to think about the whole picture.
It's like solving a puzzle.
It is. You've got your clinical symptoms, your lab findings, the patient history. You put it all together.
Exactly. It's detective work.
It is.
But for medical microbiologists, it's rewarding, right?
Oh, yeah, when you can finally figure out what it is and get the patient the right treatment.
Absolutely. Speaking of treatment, can we cure Whipple's disease?
The good news is yes. With antibiotics, it is treatable and people can have a good outcome.
That's good to hear.
Yeah.
What are the go-to antibiotics?
Well, they've used a lot of different ones, penicillin, streptomycin, but now the first choice is trimethoprim sulfamethoxazole,
Okay.
TMPSMX for short.
TMPSMX. Why the switch?
Well, it gets into the central nervous system really well.
Ah, okay. So given the risk of neurological complications, that's important.
Exactly. You want to make sure the antibiotic can get everywhere it needs to go to prevent the infection from coming back.
How long do people usually have to take TMPSMX?
Usually 1 to 2 years.
A year or two?
Yeah, it's a long course.
That's a long time.
But this is a slow-growing bacteria, and it can be very stubborn.
So highlights how persistent it can be.
Yeah.
What about people who can't take TMPSMX? What are the alternatives?
There are some, doxycycline, ceftriaxone, rifampin, but you have to be careful. Think about each patient and any drug interactions and the chance of resistance.
Right, so tailored treatment is really important.
It is.
Just like with any infection.
Absolutely.
Now, we've talked about antibiotics, but are there any other treatment approaches for Whipple's?
There is some interesting research on immunotherapy as something to use along with the antibiotics.
Okay.
Specifically, interferon gamma.
Interferon gamma. Why that one?
Well, remember we talked about the immune defects in Whipple's, the macrophage problems, the low IFN gamma production?
Yeah, the immune system is not quite working right.
Right. So the idea is that giving IFN gamma would boost the immune response and help the macrophages clear the infection better.
So it's like giving the immune system an extra boost.
Yeah, that's the idea. But it's still experimental. We need more research to know how well it works.
Okay, but it's exciting. It shows how important it is to understand the immune response.
Definitely.
Okay, let's switch gears a little. What about the long-term management of people who've been treated for Whipple's?
Long-term monitoring is really important
Okay.
because you want to make sure the treatment worked and catch any relapses early.
How do we do that?
Regular follow-up appointments and repeat biopsies, usually from the duodenum, to see if there's any infection left.
So we don't just treat and forget.
Yeah.
We have to keep an eye on things.
Right. And if somebody had neurological problems, they need their cerebrospinal fluid checked regularly too, to look for signs of relapse in the central nervous system.
Makes sense. We want to prevent any permanent damage.
Exactly.
Wow, this has been a really informative deep dive on T. whipplei. I think we need to test your knowledge a bit now, though, with a little quiz. Don't worry, no grades. Just a fun way to review.
Okay, sounds good.
Okay, first question. What's that defining characteristic we see under an electron microscope with T. whipplei?
I think everyone remembers this one.
Think about the structure.
Yeah, it's pretty unique.
The answer to that trilamellar structure.
Yeah.
That three-layered cell wall. That's what makes it so different.
Mm.
And it really confused scientists in the beginning.
Yeah, it's not just an interesting fact, though. That structure probably helps it survive and evade the immune system.
Good point. Okay, question 2. What's still considered the gold standard for diagnosing Whipple's disease, even with all the new molecular techniques?
This is a big one for diagnosis.
What are the tests we talked about?
Think about their pros and cons.
What's the most reliable? The answer is PAS staining of duodenal biopsies. PCR is great, don't get me wrong, especially in those weird cases. But those foamy macrophages filled with T. whipplei, that's still the best way to be sure.
It's a classic. You can actually see the infection.
Exactly. All right, question 3. What's the first-line antibiotic for Whipple's disease nowadays?
Now we have to think about what works best and what's safest.
Remember, T. whipplei likes to hide. So we need an antibiotic that can find it.
Got to get to all those hard-to-reach places.
Exactly. The answer is trimethoprim sulfamethoxazole, TMP-SMX. It's great because it gets into the central nervous system. And we know how common neurological problems are with Whipple's.
Plus, you need to take it for a long time, a year or two, to really wipe out the infection.
That's important. Okay, next question. A bit more immunology now. What immune deficiency is often seen in people with Whipple's?
Now we're thinking about how the immune system fights back.
What cells are involved? How well do they work against this bacteria?
We talked about how T. whipplei seems to take advantage of a weakness.
Yeah, the immune system isn't working at full strength. The answer is decreased production of IFN gamma by monocytes. This is thought to be a big part of why people get sick, and it's why researchers are looking at IFN gamma as a treatment to help boost the immune response.
Right. It shows how important the immune system is for fighting off all kinds of infections.
Absolutely. All right, last question. Whipple's disease was long thought to mostly affect men. Is that still true?
This is where we have to be careful about old ideas.
What did we learn about new research and how our understanding of the disease is changing?
Things are always evolving in medicine. We have to keep up with the latest findings.
Exactly. The answer is no. It's not just a man's disease. New studies suggest Whipple's might actually be more common in women than we used to think.
Really emphasizes the need for more research and to be open to new information.
Absolutely. So there you have it, a quick quiz on T. whipplei. I hope you learned something new. This bacteria is so fascinating. Even though it's been around for over 100 years, it still has a lot to teach us.
Yeah, it really shows you the power of microbiology and how much we're still learning.
To all our listeners out there, thanks for joining us for this deep dive. Remember, in the world of microbes, there's always something new to discover. So keep those curious minds working. And we'll see you next time.